unmute. And I am going to put my slide deck up, assuming that they're going to be joining me soon.
Did you ever? I guess that camera thing is not even active, right?
Oh, I could turn it on.
I mean, so if you hit it, your camera would be on, and the same with Eddie's. I mean, could they do it?
And here, sure. I definitely wanted to do it this morning because I was in my box. Hello, is that Bonnie?
Hi, it's Bonnie.
Aram Salzman here from Hughes Risk Apps. Can you hear me? Can you hear me okay?
Yeah, I can hear you just fine.
Excellent. I'm gonna go full screen on my slides here, and I'm gonna minimize this. Marvelous. And is it just you I'm presenting to, or are there colleagues of yours there as well?
I invited my center director. She was doing an interview at 3:30, so she might be running a few minutes late. Let me just check real quick.
Let me also say, if she can't make it, or you have other colleagues who would like to take a look at this, I'd be happy to do additional presentations, et cetera, et cetera. So very flexible about when I can show this to folks, if that's helpful.
Okay, let me just check and see if she's going to join. If not, we'll do this one, and then we can get her back if we need to. Okay, good. That's what I thought. Okay, well, we're there. Just okay. Bye. Yep, that's what I thought. She just said she finished her interview. She's jumping on.
Oh, great. I will also say, joining me just viewing on my end is Greg Gillette. He's one of our new sales folks. He actually won't be covering Texas, but we're in the process of ramping up and hiring folks. My official capacity is CEO and chief sales guy. But as we ramp up the team, I'll probably bring on some additional sales folks, and at some point along the way, I may introduce a salesperson to you. But I'll work closely with them as they get up to speed as well, regardless. So consider me your point of contact for the time being, and possibly going forward as well.
Okay.
Oh, and I see Elizabeth Lewis just joined us as well.
I am here.
Hi,
Sorry
Elizabeth.
for being late.
Oh no! If you're maybe a minute late, heaven forbid! My goodness. Aram Salzman here from Hughes Risk Apps, and I was going to give you folks a 3-4 minute slide presentation that gives you a little bit of background about our company, and then I'm going to leap on in and show you how Hughes Risk Apps works. So I was saying to Bonnie a second ago, I'm chief salesperson, but I also moonlight as CEO of the company. We just raised an investment round a month or two ago, and we're adding both salespeople, installation and support folks, and programmers. But my own background is in sales and marketing, so I'll probably always keep myself involved in the sales and marketing process. You can work with me going forward regardless. Our founder, Kevin Hughes, is really one of the global thought leaders in cancer risk assessment, and specifically breast cancer risk assessment. He is a breast surgeon at Massachusetts General Hospital here in Boston, and he's also the co-director of the Avon Center for Breast Health at MGH. He also
Wow.
I'm sorry. What was that?
I just said wow.
Oh.
I said wow.
He's a great speaker too. Down the road, if you'd like to spend some time talking to him, he's really he's very good at how all of this should work, what it means to run risk assessment for a breast center, he gave one of the keynote speeches at the Society for Breast Imaging's annual meeting earlier this year, and it was there were 700 radiologists in the room, and if I do say so, he did a very nice job of sharing with them how this should all work. Our chief technology officer is Brian Drowan, and I'll leap in and tell you a little bit more about what we do. We're the leader in this space. Our mission as a company is to identify high-risk patients for screening and prevention, to improve patient care and outcomes. In the imaging world, there is sort of a corresponding piece, which is that if you're doing mammography and you're screening your mammography population, we can also help your radiology group significantly increase their breast MRI revenue. So if you can get radiology on board with this and use it as a screening tool, it's very easy to get the finance folks to approve it, and you'll also have some rather happy radiologists as well. And I can if you're discussing budgeting for this and how you're going to pay for it, et cetera, I'd be happy to walk you through some of those return on investment issues as well.
Okay.
So this software has been around since 2006. Locally here in the Boston area, Newton Wellesley Hospital has been using it since 2007. They use it to identify women at risk for genetic mutation, to identify women who have elevated lifetime risk of breast cancer, and also use the tool for colorectal cancer risk assessment as well. The company was spun out of Mass General Hospital in March of last year, and as I mentioned just a couple of months ago, we raised some investment money to help grow the company and turn us into a more of a commercial endeavor. How this all works? So in the imaging universe, there are established guidelines for MRI screening, and interestingly, 99% of the women who should be getting a breast MRI according to guidelines are not getting them today. On the flip side, the very few breast MRIs that are being done, many of them do not actually meet guidelines. So in this one particular area of breast health, it's very challenging without an automated tool to screen the right folks to identify who should be getting breast MRIs. On the broader realm of risk assessment for breast cancer in general, this is our medical advisory board. Dr. Juhas is one of the other real gurus in risk assessment and the creator of the Cancer Gene tool. Dan Kopans, also at Harvard, is one of the real, for many years, one of the real leaders in women's imaging, both in the development of tomosynthesis, breast MRI, breast ultrasound, and CT. Mark Lippman at University of Miami Medical Center is the chairman of the Department of Medicine, but formerly head of the medical breast cancer section at NIH. And he's actually in the process of getting Hughes risk apps for University of Miami. They're in the final stages of negotiating a contract with us. So he's both very supportive, big picture in terms of what we do as being a member of our medical advisory board, but also, believes in what we do to the extent that they're actually going to be using it at his institution. Giovanni Parmigiani is one of the primary developers of one of the models itself. That he's one of the creators of the BRCA Pro model, and he advises us on risk modeling in general. To take a little bit more of a 1,000-foot view, the Affordable Care Act Meaningful Use Phase 2 and 3 say that we should be looking at how family history impacts patient care and health. In many disease areas, I'm not even sure what that means. In breast health, interestingly enough, it's one of the areas where the correlation is very clear. A patient's family history may have a very immediate impact on their health, and yet looking at that in a meaningful way is not so easy. There are screening and prevention guidelines for many conditions, but meeting those guidelines for clinicians who are actually out there practicing, it can be very challenging. We develop risk assessment tools for guideline appropriate care with a secondary focus on return on investment for healthcare providers. How does it actually work? So integrated screening and decision support tools. Patients can enter their own family history and risk factors either on a tablet computer or even remotely from home via internet. Risk calculations using the accepted models and recommendations based on guidelines happen automatically, and high-risk patients receive the appropriate screening, whether that's MRI screening in mammography, in radiology, or women at elevated risk of having a BRCA mutation, can get recommendations for genetic testing. The system can even be set up for very high risk patients. You can even have triggers set up for making a recommendation for chemo prevention for high risk women, or even prophylactic oophorectomy or mastectomy. Obviously, is also an option for women who are at elevated risk. All of that can be wired into the system as it's set up. Newton Wellesley's experience using the system over many years basically flags that 15% of the mammography population will have a greater than 20% lifetime risk of cancer, according to one of the accepted models. So for every 1,000 mammograms performed, we should be doing roughly 150 breast MRIs. Looking at the broader spectrum of existing MRI utilization in the United States, this Wernley study looked at nearly 1,300,000 screening mammograms that were performed. In that population, only a little under 9,000 MRIs were done. So 4.3 per thousand, or 0.4%, were actually given MRIs. So we should be flagging 15%, but nationally we're at 0.4%. It's clearly challenging to identify the appropriate women to get breast MRIs. In this Wernley study, those very few women who actually got MRIs, 75% of them did not meet guidelines. So good luck getting reimbursed for those MRIs, but it's obviously not trivial to give breast MRIs to the appropriate women. So guideline-based tests and procedures recommended to the physician on the fly automatically. High-risk individuals receive letters for follow-up and are tracked for compliance. So we can send a letter to the patient or the PCP, depending on your preferred clinical workflow, flagging the high-risk and low-risk patients, and then track whether patients have gotten the recommended follow-up screening. Here's an example of a letter that we can create that can be sent to the PCP, a draft letter for the PCP to use with the patient's insurance company, stating that it's a case of medical necessity for this patient to get a breast MRI. She's at elevated risk according to one of the accepted models, and according to American Cancer Society guidelines, a patient with a greater than 20% lifetime risk of breast cancer should get an MRI. This particular patient's score on the Tyrer-Cuzick model is 34%. The goal of all of this is for women to have the screening and prevention they need to prevent needless cancer death. I'm going to hop out of my slide deck and actually show you the working tool. Any questions at this point?
Not yet.
All right, so let's pretend now that I'm one of the support staff at the front desk in my breast center here, and Joan Doe walks up for her mammogram appointment, and we say to her, Joan, thank you for coming today. One of the things we're doing in our breast center now is, over and above the annual mammogram, which we've recommended for quite a while, we're also doing a brief cancer risk assessment. Can you confirm that this is your name and date of birth? And she says, yep, that's me. Wait a second. Excuse me. I clicked. Hold on. Excuse me. I think I set this patient up incorrectly. Can you excuse me for 1 second? I just want to pull that patient up. I don't know if I had her set up for my. Oh no, I didn't. Excuse me. I had her set up for a slightly longer risk assessment. We have 20 or 30 different risk assessments, and the one we use in screening is typically shorter. The one I had her set up for, was breast colon risk, which is a longer risk assessment, and I wanted to use my screening risk assessment for her, which is internally we call that super short breast. So I knew something was looking funny because one of my questions was missing for the screening. I'm gonna log back in. Please excuse me. When I set up this demo patient a little earlier, I must have clicked on the wrong button. So here she is again. we ask her to identify herself, and I knew that my super short breast risk assessment, the first thing we start off with is a little blurb to explain to her why we're doing this. So completing this questionnaire will help us understand your family history and other risk factors. We can help identify if your family might benefit from additional screening or testing. And this is part of our commitment to providing the highest possible care. If you don't know the answer to a particular question, don't worry. That's fine. Skip ahead. You don't have to answer every single question in the risk assessment. So now we're going to leap right in and start doing the risk assessment. The patient could switch languages if she wanted to, Spanish, Portuguese, French on the fly. I'll switch back to English here. My imaginary patient is 5'5", weighs 170 pounds. We're calculating BMI here, and has a glass of wine after work every day. We're also going to ask if she's a smoker, and I'm going to make this intentionally a high-risk patient. She had her first period at age 12 and is still having them. She's never been pregnant. Again, I'm intentionally making this a higher risk patient. And many of our questions have branching logic. The net result of that is a patient who's at very low risk probably gets done with the risk assessment in 4 or 5 minutes. A higher risk patient may take 7, 8, 9, maximum 10 minutes or so to complete the risk assessment because they're going to end up answering more questions. So if I say no to biopsy, I skip ahead. If I say yes, we're going to ask this patient another question or two. How many biopsies have you had? I'm going to say 1. And then we're going to ask if she's aware of the diagnosis that was given on that biopsy. We certainly want to capture that information. I'll say no to atypia here, and I'll also say no to LCIS. Either of those would obviously increase risk for this patient. We're going to say my imaginary patient is Caucasian, and then we have a secondary question as to whether she's of Hispanic descent. Being that you're in Texas, you're probably aware that women of indigenous South American descent are at decreased risk of breast cancer. I'm going to say no to this question. And then we have a secondary ethnicity question as well with regard to Jewish descent. I'll say no to that one. Being of Jewish descent would increase risk, of course. I can capture whether they're of Sephardic or Ashkenazi Jewish descent, but for the sake of a screening scenario, we just ask Jewish descent. So now we're getting into the nitty-gritty of it. This is for the patient. Have you ever had cancer? I'm going to say this patient has a history of lymphoma, and she was diagnosed at age 28. This triggers a secondary question. Did you have chest radiation treatments between the ages of 10 and 30? And I'll say yes. Have any of your blood relatives had cancer? I'm also going to say yes here. We're going to say we had a sister with a history of ovarian cancer. She was diagnosed at age 35. And now we're going to go to second-degree relatives on the mother's side. We're going to say a maternal grandmother had a history of breast cancer at a young age. We'll say not in both breasts, just in one, but we'll say she was diagnosed at age 35. And now we're going to go to the father's side of the family. One thing I should say, wherever possible, our goal is always to make these questions, answered at a very answerable by someone with a fairly basic reading level. So some of the medical terminology obviously gets a little beyond that, but we always shoot for having, someone with a 9th or a 10th grade reading level being able to answer most of the risk assessment here. I just added 2 more affected relatives. We're going to say the grandmother had a history of breast cancer, again, just in one breast, at age 40. And we'll say that the grandfather had prostate cancer. And again, in the name of simplicity, all of our cancer choices are gender specific. We have a male affected relative now. Ovarian's no longer an option. Prostate is an option. Again, we want to, as much as possible, eliminate the possibility for error. We don't want grandpa to accidentally be able to click and say he had ovarian cancer. That certainly wouldn't make a whole lot of sense. The grandfather was diagnosed at age 52. And last question here, has the patient had genetic testing? I'll say no to this one, but if they say yes, we can capture their BRCA status. I'm gonna click to the next screen, and the patient wouldn't see this next screen, but now I'm scoring all the risk models on the fly. This would happen in the background in the real world. What the patient will see, and you'll see in a second, after the risk models are done running, what the patient will actually see is, please return this tablet to the front desk, and they're done. One other thing for my demo system is we're actually seeing the documentation that the system is generating on the fly automatically. So, and again, in a real system, this would happen in the background on your server. You wouldn't see it, but it looks kind of whizzy and cool in a presentation. So you're seeing all the stuff we generated. The first thing we generated for this patient is some smoking cessation information, and you can actually bill for giving a patient who's a smoker smoking cessation information. We also generate. I'll get to this piece in a second. We also generate some of that PCP focused correspondence that I discussed earlier. Here's a letter to the patient's internist or OBGYN, who's the PCP for this patient. And as I meant, this is a high-risk patient, so she's getting an MRI recommendation based on her Tyrer-Cuzick score. We also have a little blurb at the bottom here telling Dr. From Dr. Samin to the PCP, by the way, given that we're making an MRI recommendation for this patient, I've also attached a draft letter of medical necessity that you can use with Joan Doe's insurance company. And in fact, here it is below, directed to the medical director of her insurance company. The PCP could cut and paste this onto their stationery and get pre-authorization for that MRI study. I'm going to copy this patient's medical record number because I'm going to use it a little later as I take a bit of a deeper dive. So the next piece I'm showing you here, this is the full risk assessment for this patient. And it really depends on who's looking at this. My assumption is in your new, I'm assuming you're going to be doing mammography in your new center. Is that a fair statement?
Yes.
Yes.
Gotcha. So assuming you have radiologists who are reading mammograms, typically what that radiologist will want to see first, if they're doing risk assessment in the facility, they're going to want to see all of the decision support recommendations we make for that patient on the fly. So we have 3 recommendations that were made for this patient. Genetic testing is suggested because she has a greater than 10% risk of mutation, according to the BRCA Pro model. We have our primary MRI recommendation based on her Tyrer-Cuzick score, and we have a secondary MRI recommendation based on the fact that she had chest radiation therapy under the age of 30. And quite a few of our clients are actually asking, the radiologists are actually asking to push a copy of this risk assessment into the PACS so that the first thing a radiologist sees just before they read the mammogram is our recommendations and the full risk assessment if they want to take a look at it. We can also send results out to your mammo reporting system or your
Sorry, that was my phone.
I love the Beatles. I could sing along a little bit too, as always. So we can certainly push a copy of this risk assessment to the PACS, or include as much of this as you wanted as a note in your electronic health record or your mammography reporting system as well. As I scroll down, we're seeing all the answers to the questions that the patient made, and perhaps a little much for your average radiologist, but if the radiologist really wants to take a deeper dive in the risk assessment, they can take a look at all of the scores that this patient got on their risk assessment. So we have their risk of mutation, 5-year cancer risk, lifetime cancer risk, ovarian risk, and then we did actually do some colorectal risk assessment as well. We have their risk of Lynch syndrome mutation. We have their 5-year and lifetime colorectal risk as well on various models. The last piece that we can create here is we can also create a family tree, a pedigree for this patient on the fly, and that's in essence the screening and decision support piece of what we do. We also have a back end which it really depends. If it depends on what you're going to do with high risk folks, and whether you want to take the extra leap and do genetic counseling or other follow up, etc. On a basic level, we will. This is our clinician dashboard. We will track all of those patients who have a greater than 20% lifetime risk of cancer. Those are the women who should be getting an MRI. So we, generate automated follow-up letters, flag them in our system, and maybe your administrative staff will run a report every 30 or 60 days to see who on that list actually got a follow-up study. If someone gets the MRI, they can go into the system, tick them off so that they're not on the recurring list. We can track all patients who are at elevated risk of having a mutation. This can be used as a powerful outreach tool for your facility. If someone is at elevated risk, they may say, hey, to their sister, you should go on into the breast center there, over and above my mammogram. They did this cool risk assessment thing on me. And the patients at Newton Wellesley have said for years that they see this as a very favorable thing that their proactive breast center is doing for the community. But as the sisters get referred in, you can track entire families and have risk assessments done on them. You can do additional screening, genetic testing, etc. But tracking and follow up for these folks is a lot of what we do as well. If you're just focusing on imaging and MRI, we can do that. But if you want to take a broader leap and sort of track and follow up for genetics, we can even and this is really more in a cancer network hospital cancer center setting. I'm not sure if that's relevant to your group overall, but I'm taking this particular patient and I can even pull her into my risk clinic. Let's say we do suspect that there's a mutation in her family, and I can do a much more involved pedigree as well. I can add relatives. Now I'm going to add some unaffected relatives, which a genetic counselor would say is important as well. 2 brothers and a sister. She has an aunt and an uncle who are unaffected on the mother's side and 3 aunts on the father's side. I can add those relatives in bulk. I can also add relatives at the pedigree level if I want to. And I can even say, this particular grandmother has a cancer history, at age 50. And even though I just added this additional affected relative at the pedigree level, it populates back to the database, and I could rerun my risk scores. This gets, and again, it really
that gets really detailed.
Yeah, this is really more oriented towards running a risk clinic and having a genetic counselor, et cetera. But I just wanted you to know that functionality is there. In an imaging setting, it's really the front 2 pieces that most folks would use. Anyhow, the goal of all of this is screening, decision support, tracking and follow-up. And our primary goal is to make it simple for the patient and simultaneously minimize the workflow impacts, certainly on the radiologists, but also on the support staff as well. We want to automate as much of this as possible, let the patients get the screening they need, allow the practice to track and follow up those patients who need to get additional imaging studies, and automate as much as possible. But that's a pretty good run through. You've seen screening, decision support, tracking and follow up.
So you said that you basically hand tablets to patients to fill this out and then return the tablet to the front desk with the short or the super short
screening risk
screening.
That's correct.
When you buy the software, do you buy the software and then we buy the tablets that we want to use in the center, and then do you do this but do you have user license, or how does that work?
Yeah, so this is we will set this up in your data center running on your servers. You buy the, so it runs on your servers in your center, and you buy whatever tablets you want. All we care is that the tablets can access a web browser, and it will typically run, as a little internal website inside your hospital network. And unless you use our web option, it's running inside your system. And in terms of pricing, it's essentially $2 per screening mammogram per year to run the system. I'd happily put a proposal together for you in terms of your volumes, et cetera. But one key piece that we do, I'm pulling it up right now, is because this has such a significant impact on breast MRI in your center. This is our return on investment calculator on our website. But let's say your reimbursement for a breast MRI is $800, and you do 10,000 mammograms a year. Once you're up to speed at your center, assuming that 15% of those actually, meet the American Cancer Society guidelines, and that's what's typical nationally. Even if only 1 in 3 women follow up and get a breast MRI that are flagged as being high risk, we're going to bring an additional $400,000 in revenue into your breast center, and your annual fee to us is only $20,000 a year.
So you charge this on a per click basis? How many mammograms you do? It's $2 per mammogram?
Yeah, precisely. And typically we recommend redoing the risk assessment every time the woman returns for a mammogram, in part because obviously things change. Additional relatives may have cancer, there may be hormonal changes, et cetera, et cetera. When a woman returns at the second or third year, the system is pre-populated with the risk assessment she completed the previous year, so all she has to do is zip through and indicate if there are any changes.
So do you have a minimum or?
No. From the sounds of it, it's you said you were just starting out in your breast center, so there are some interface costs, et cetera, but the startup costs are just based on your volume.
Okay, so if we say we get started, and there's you said startup costs by some upfront costs
in terms of the setup and the interfaces, et cetera. And then every year as your volumes increase, we'll give you a little notice. You did X and so number of screenings last year, so your annual fee for the coming year is going to be based on the prior year's fee.
So it's a upfront cost. So you pay it like so. If I tell you we expect our mammography volume to be 10,000 a year, we're going to pay you 20,000 in advance, and that's our fee for the year.
Yeah, and you can do it in advance. You can do it quarterly. You can do it monthly. Whatever's easiest for you financially.
So what happens if we tell you 10,000 but we only do 7,000?
Oh, we'll rebate the difference. We'll rebate the difference, and if you're paying monthly, we can adjust it as we go.
And then on the flip side of that, it was just as we went forward, and then we would put it on one of our servers in our system, and then we would just buy. If we decided we needed 5 tablets to give out to patients, the front desk, we just have 5 loaded on 5 tablets.
Yeah, and we don't care how many tablets you run. Typically our experience is that for a given tablet computer, you can do 5 or 6 risk assessments an hour without getting into any trouble. So you project your rough mammo volume, you buy the appropriate number of tablets, as your volume goes up, you might add a tablet or 2 here or there.
Okay, and there's not is there any other fees or charges or guarantees or anything that we contractually?
The only other and you can cancel with us any time with 90 days notice. The other setup pieces are assuming you want us to connect to some of your host systems. Typically, we'll pull your appointments in from your scheduling system and send results out to one or another of your systems. And so each of those has a setup charge associated with it.
Okay. Well, that's interesting.
So just, I know you say you'd have to run the numbers, but just on a 10,000 patient basis, what do you guesstimate the total cost to be for startup?
So
For
very
the
very
first
roughly, you probably need an inbound and an outbound interface. So that would be $10,000 of setup charges, and then $20,000 a year for the per click fee, and that's it.
So you need an interface. Is it an HL7 interface between you guys and
We
And,
we can
the center?
for the inbound interface, we can either do a flat file or an HL7 ADT, and the results interface is up to you. We'll do HL7. We'll do just a straight note to your mammo reporting system. You know, whatever interface spec is easiest for you. Certainly HL7 is the most standard, but in mammo reporting, that's not even always what folks want. Sometimes they just want a straight note pushed into their mammo report, and that's it.
Well, the report is we're using, we have a Fuji RIS and PACS.
Okay. Yep.
So the report would go into the Fuji RIS.
Okay. And whether even within that Fuji RIS, whether you want a full-blown HL7 results interface or just a little note pushed over, that's something we could work out, assuming we forge it ahead.
Okay.
I have a,
Go ahead, Liz.
I have a question about the reports. You said they're customizable.
Sure. Yeah, so there are a couple of different pieces. I'm just scribbling a note to myself for a second here. The letters that you saw can certainly be customized. We have lots and lots of different automated correspondence that we can generate. Whether, one scenario is that we're just piggybacking on your mammo reporting. Another scenario is that we're just sending completely separate risk letters either to the PCP or the patient or both. And that really depends to a large degree on your preferred workflow. Some of our clients just want to send notifications to the PCP. Others report directly to the patient, and there are different ways that can be done. Some folks will say to the low risk patients, a risk assessment was done during your visit. You're at low risk, and then the high risk patients will get a note saying a risk assessment was done during your visit. Please talk to your PCP with regard to the results. And that's for those folks who don't want to report a high risk directly to the patient for fear of scaring them. That said, interestingly, Newton Wellesley, our first site, has always reported risk directly to the patient. If you're low risk, you get a low risk letter. If you're high risk, you get a letter saying we did a risk assessment. You have a greater than 20% lifetime risk of cancer, and you should schedule an appointment with your PCP to discuss what this means and next steps.
Do you have any calculations or able to calculate, say, or even mention about the dense breast tissue and the recommendations for additional testings as a result of dense breast?
So coming soon to a breast center near you. The key piece on with regard to density that we're all waiting for. The Tyrer Cusick folks, Jack Cusick, published in the fall of last year an update to his approach that is density adjusted risk, and they're still validating the final version of model for public release. But as soon as that happens, hopefully this summer or at the worst this fall, we'll actually be able to do density adjusted risk modeling on the fly with one of the accepted models. We're even in discussions with Volpara and Hologic potentially about getting some of those quantitative density values from one of those systems on the fly, pulling it into Hughes Risk Apps, and then being able to do automated density adjusted risk modeling on the fly. So we're very proactive on new models and new approaches, and we're all the other model that's density adjusted risk is the TICE model out of UCSF, and they're actually asking us to code to actually create the programming for their density adjusted risk model. So we will be running density adjusted risk models as soon as they're available.
And that'll just be part of the package. It
Correct.
won't change.
Correct.
Yeah.
You know, so we're always adding models, updating models, et cetera, et cetera. When a model is added or updated, you get it as a matter of course as part of your annual fee. You know, and if you want to make changes to your workflow, we do that. We do that for you as well.
Okay. So
Okay.
this app is similar to something like the apps you put on your mobile devices?
You know, it's a little more involved than something you would run on a mobile device. It's you know, because the calculate. Oh, you mean in terms of what runs on the tablet itself?
Yeah, basically.
Oh,
Is it
so
like
so
the
we actually
icon?
all we need on the tablet is to run a web browser. Actually, we're not even in that sense. We're not, you know, we're not like a downloadable iTunes app or something like that. Literally, all you have to do is pull up a web browser on that tablet. We typically lock the tablet down, so all it can do is pull up a web browser, open that one website, and you're running it through a web browser on the iPad.
Okay, that's what I was wondering, if the iPad could be used for other things, but it can only be used for the Risk app.
Down the road, we will actually be developing an iTunes, an official iTunes app. But, you know, for example, let's say you wanted to run some other patient application on that iPad, we would work with you to set it up so that it would allow, you know, you could access, you know, that one web URL and whatever other app you needed to run. We'd work with your IT team. You know, we don't need to hog that app specifically for Hughes Risk apps. So if there are other things you want to do in the process of locking it down, we would restrict it to the 1 or 2 or 3 things that you deem acceptable.
Okay. Okay.
Okay. Well, I think that answers a lot of our questions. I think, Liz, we need to probably see if we can get another few minutes with probably with Dr. Roberts. She's our breast radiologist, and maybe Dr. Dickey, who's our head of women's services, so that they can take a look at this and see what they think, and then I can discuss the cost of it with Dickey, since we don't have this budgeted. But if we can make a, you know, if it's something they're interested in, and we can make a case that it's going to increase our MRIs at the IDTF next door, I think that, you know, we may be able to justify it that way. And it also just it answers the issue about how we're doing risk assessment that she wanted to do in the center. I like the fact that it's charged on a click basis, even though we have some upfront costs, which I can talk to Baka about how that would go with Fuji. But at least that way, it's on a, you know, as we grow the volume, we don't have a big cost up front that we, you know, while we're trying to really get the volume in the center, that it's going to grow with us, in other words.
Gotcha.
Yeah.
Gotcha.
And then those, and just so I'm clear, after the initial startup, it's strictly on an annual basis. It's just strictly the per click.
Precisely.
There's no other maintenance fees
Nope.
or.
Nope. It is.
And it doesn't matter. You said there were like 20 different risk assessments on there. Would it only be loaded for breast, is it only in that one location?
No,
or
up to you. You know, for example, if you wanted to expand beyond breast and starting to do some colorectal risk assessment, we would just set you up for colorectal risk, and you could roll it out in your GI department. So,
And then it's still the per click fee?
Still per click. That's correct.
Okay.
Now, that's interesting because we do have 3 brand new GI doctors that just joined, and they're doing a GI lab in Arlington. So there might be some interest in that too.
Gotcha. I would say if Dr. Roberts or Dr. Dickey would like, a follow-on demonstration, I would be very happy to do so. Would you like me to put together just a first draft of a proposal so you have something concrete to show them?
Yeah, that'd be great.
What would be a good starting memo volume to put in there just for budgetary sake?
Well, we used 8,000 in our for the first year in our performance.
Okay.
So that I think we're going to have. I think we're going to outperform that, but conservatively, that's what we used in our performance to get started.
Great. That's where I'll start. And I'm pretty sure I mentioned when we spoke last, Bonnie, but just to refresh your memory, we've had a pretty big presence in Texas Oncology for quite some time. They use us more the nerdy risk clinic piece that you saw, but they use it at 15 of their 26 centers around Texas, and they're in the process sometime over the course of this year of expanding it to the rest of their centers. So we have lots of happy customers in Texas.
Okay, good. And Texas Oncology does that?
Correct. The physician who's really driven that is a Dr. Sandbach, and his right-hand person is a woman named Gail Patel. But 15 Texas Oncology centers live using this system today.
Okay.
The only other thing I would say is, feel free to ask questions. I have a running joke that if you folks haven't asked me 100 questions, then we haven't worked hard enough here.
Well, we probably haven't asked you 100, but that's because we're just trying to sort this out for us. So
going forward, fire away, and certainly if it gets to a point where you're thinking seriously about going ahead, I'd be happy to talk to your IT department. But I would obviously welcome a discussion with Dr. Roberts and Dr. Dickey as well.
Okay, well, we'll see what we can corral, and then if you can get me that, if you can give me the first draft, that would be good.
Yeah, I'll get that out to you tomorrow for sure.
Okay. Anything else, Liz?
No, not that I can think of.
Okay. Hey, I know we needed to go over that requisition, but I'm got a dash because I didn't realize that Cameron has a flag football game tonight, so I got to get home to get to that. So we'll do it in the morning. You coming here in the morning?
Yes, I'll be there.
Okay, so we'll nail that down in the morning when you're here.
Okay. I'll come before our standard, our regular meeting because.
Yeah, come earlier than that. I'll be here.
Our regular meeting. Okay. All right.
Okay.
I'll see you in the morning.
Amos, thanks a lot. I appreciate it, and it's interesting. And let us run the traps on it. You get me the quote, and we'll see if we can't set up another webinar time that they can agree to join. It might need to be like this time or a little bit later to catch them after clinic hours.
I don't care if it's 6 in the morning or 6 at night. No worries. That's fine.
Okay, perfect. All right,
Great.
thanks, Abram.
Excellent. Well, thank you for your time, and I hope Cameron does well in his flag football game.
Yeah, he's a mess. Yeah,
Excellent. Tell him to go knock him down.
All right, I will.
All righty. Have a good one.
Thanks. Bye.
Bye.
I didn't even think of it. I probably should have given them a heads up that I was recording it, but
Yeah, it's all right.